Ambulatory anesthesia. Definition: ambulatory anesthesia is anesthesia provided for ambulatory surgery, which refers to surgical or diagnostic interventions performed with traditional hospitalization that could in most of cases be accomplished with complete confidence without a night of hospitalization. Among other specifications, these procedures require technically sophisticated facilities, as when done on an inpatient basis, rigorous and meticulous preoperative selection procedures, postoperative follow-up of several hours. One of the most simple and universally accepted definitions is daycare surgery, that is, the patient being discharged from the hospital on the same day of the surgical procedure. Indications: several factors have encouraged and boosted the concept of small incisions and minimal invasive surgeries, thus allowing for more surgical procedures to be performed on day care basis, among which the fast pace of life, the need to early return to work and resumption of daily routine activities to maintain social and professional competitiveness, the relative shortage of beds in hospital, and scarce economic resources due to ever-increasing and continuously increasing the patient population. General look. Challenges to ambulatory anesthesia. The main challenges include the organization of the daycare setup to make it function efficiently, effectively, and safely. These difficulties are accentuated in resource-challenged settings, and we mean by this the developing countries. History. An exclusive ambulatory surgery hospital was first created in 1969. The formal development of ambulatory anesthesia came into an existence with the establishment of the Society for Ambulatory Anesthesia in 1984. Statistically speaking, it is estimated that 66% of surgical procedures performed on outpatient basis in the United States, whereas only 50% of surgeries in the United Kingdom are performed on daycare basis, with an ambitious target of 75% over the next decades. Anesthetic concerns. The advancements in anesthesia techniques and availability of newer drugs have contributed largely to the progress of daycare surgery. Anesthesia for daycare surgeries, or ambulatory anesthesia, may require administration of general, regional, and local anesthesia, or monitored anesthesia care supplemented with sedation. Potential benefits are the lack of dependency on availability of hospital beds, greater flexibility in scheduling surgeries, reduce the incidence of nosocomial infections, shorter surgical waiting lists, and lower overall procedural costs. Also, there is higher volume of patients, leading to higher efficiency. Recovery in a familiar environment at home, contribution to the economic growth of the nation by reduction of the absenteeism from work. On the other hand, ambulatory anesthesia do possess some disadvantages, among which surgical and anesthetic complications resulting in unplanned readmissions to the hospital, need for higher expertise levels, possible chances of negligence in preoperative anesthetic assessment, lesser compliance to preoperative fasting instructions and the preoperative medications, higher anxiety levels among the patients because they are transmitted from the domestic environment at home suddenly into the operative environment. Preoperative considerations. Preoperative patient selection. Patient screening and selection is one of the primary important requisites for daycare anesthesia and surgery. Patients are selected for such procedures based on some important guidelines, such as patients must understand the delicate specifications of daycare procedures. During discharge from hospital, an adult person should accompany the patient with written instructions. The domestic environment should be conducive enough for smooth postoperative period. Both basic minimal laboratory investigations and the clinical examination are very important in deciding the fitness for daycare surgery and anesthesia. Comorbid diseases should be optimized satisfactorily before declaring the patient fit for surgery. Patient should be able to initiate oral intake within few hours after the surgical procedure. Anesthetic drugs and the techniques used should not disturb the postoperative ambulation. The patient should be able to take care of himself or herself. A good means of transport and communication should be available to the patient at home. Availability of the physician or surgeon for 24 hours is an essential point in case of any emergency readmissions. Preoperative evaluation. It is a very important issue and we can consider it as a foundation of the building. At this stage, a detailed history and a meticulous examination can help in the identification of medical comorbidities and risks associated with surgery and the initiation of appropriate measures to optimize the clinical status. Comorbid diseases such as hypertension, diabetes mellitus, morbid obesity, and others are not considered contraindications to daycare anesthesia in the current practice. Antihypertensive drugs are taken as routine on the morning of surgery. Optimal control of blood pressure helps in providing cardioprotection, and it preserves the renal functions and attenuates stress response. Diabetes management includes stoppage of oral hypoglycemics a night before the surgery, no insulin injection on the morning of surgery. Morning report of fasting blood glucose is extremely helpful. Patients with diabetes should be taken up as first case to avoid the metabolic consequences due to long fasting status. There is no need for tight control of blood sugar level in stable patients. Reduce the postoperative fasting and manage nausea and vomiting promptly postoperatively to avoid their consequences. Preoperative evaluation of diabetic patients is mandatory to detect and manage comorbidities. Airway problems during the perioperative period, as difficult mask ventilation and intubation, can increase the incidence of complications perioperatively. Anesthetic techniques are chosen on patient-to-patient basis and the type of surgery. Generally, it is better to avoid general anesthesia in patients with active respiratory infections, hyperactive airways, and sleep apnea syndrome. However, many patients may be considered as not candidates for daycare surgery, and these include patients with history of venous thromboembolism during the past 3 months, patients with prosthetic cardiac valves, patients receiving higher doses of anticoagulant drugs, and we mean higher than the prophylactic doses, patients with critical or low platelet count, patients with neurological disorders and autonomic neuropathies, patients with neuromuscular disorders such as myasthenia gravis and muscular dystrophies for the possibility of postoperative respiratory problems indicative of ICU admission and mechanical ventilation. On the other hand, renal and hepatic diseases are not considered as contraindications if they are controlled. Surgical factors in the preoperative evaluation process include procedures with high propensity for cardiovascular instability, hemorrhage, postoperative nausea and vomiting, delayed start of oral intake, are not suitable for daycare anesthesia. Intraoperative considerations. Pre-medication. It is recommended that clear fluids can be administered up to 2 hours before surgery. Routine administration of metoclopramide and H2 blockers to ensure minimal residual gastric volume and acidity is a good practice. General anesthesia. Use LMA, the Procil type, or other simple airway management devices. Inhalational agents as sevoflurane and desflurane are better than the usual agents for fast and smooth recovery, but this is, on the other side, more costly. TIVA, total intravenous anesthesia. Using propofol, midazolam, remifentanil, and dexmedetomidine is one of the excellent methods for general anesthesia in ambulatory anesthesia. Using rocuronium, succinyl choline, atracorium, or cystatracorium is excellent also as neuromuscular blocking agents when providing general anesthesia in ambulatory cases. In pediatric, geriatric, ophthalmology, and ENT surgeries, all of these methods can be performed. Regional anesthesia. Neuroaxial, modification of local anesthetic dose to reduce time for block regression, use of adjuvants, low dose unilateral spinal anesthesia, smaller needle gauge, less than 25. Ropivacaine and levobupivacaine are among the safest local anesthetic agents that can be used in ambulatory anesthesia. Beer's block. New safer local anesthetics can be used in Beer's block with the help of adjuvants. Ultrasound guided peripheral nerve blocks. It provides us with more precise, more successful technique and lower local anesthetic doses used. Wound infiltration with local anesthetic. Simple, safe, and effective technique. It is even more challenging to provide anesthesia for emergency daycare surgery. So it is ambulatory anesthesia for emergency procedures, and the examples are close reduction of bony fractures, tendon repairs, laparoscopic procedures such as appendectomy and cholecystectomy, ectopic gestation and DNC, wound debridement, and other incision and drainage procedures. In these cases, the discharge decision is a matter of counseling between the anesthesiologist and the surgeon. Monitoring. 3 M's, minimum mandatory monitoring, includes non-invasive blood pressure, oxygen saturation through oxygen pulse oximetry, electrocardiography, with addition of endotidal CO2 and bispectral index. This will be very useful and helpful. Post-operative considerations. Recovery. The main aspect during the post-operative period. Please avoid bradycardia or hypotension, hemorrhage, post-dural puncture headache, transient neurological symptoms, pain, respiratory depression, urinary retention, shivering, and post-operative nausea and vomiting. Recovery stages. Recovery is usually divided into 3 stages: early, intermediate, and late recovery stages. In the early stage, patient getting awake with return of protective reflexes. The intermediate stage, it starts with the patient getting admitted into the post-anesthesia care unit till discharge of the patient. Any complication during this stage can be easily managed as the recovery unit of daycare surgery is well equipped and staffed. Late stage of recovery, it terminates when the patient fully recovers from the physiological and psychological aspects of the surgical procedure, with the ability of the patient to take oral fluids and the ability of self-ambulation for micturition, for example. A written set of instructions and the contact number of attending doctor should be handed over to the patients and the accompanying persons during discharge, and should be told to contact immediately on appearance of any signs and symptoms. Ideally, such patients should be handed over summary of general details of daycare anesthesia and the surgical procedure done. Recovery characteristics. We can say confidently that the patient has recovered anesthesia if there is a good coordination of various sensory, motor, and psychologic functions of the body, correct orientation to time, place, and the person. Recovery from neuroaxial anesthesia should be assessed by return of lower sensory levels more than S3 level in the perianal area. Stable blood pressure reading, especially related to orthostatic mean arterial blood pressure. Patient should have a good peripheral sensation, ability to self-ambulate, normal flexion and extension movements at foot. Adult should be available to take the patient to home as well as supervise the patient later at home. A good communication with the attending surgeon or anesthesiologist should be achieved. Availability of personnel or reliable transportation. And above all, patients should be able to understand the requirements of post-anesthesia care and should follow advice as to when to resume daily routine activities. Thank you very much.